actually, because it has negative connotations. But the proportion of mental health problems that we're seeing in UK primary care is actually really significant. And this is why we're talking about mental health and substances. I think also with the darker nights and earlier, it's getting darker earlier. It's cold, people start to get a bit more depressed, I guess, and a bit low mood, and seasonal affective disorder, and also, look, it's really cold. If you are homeless, more likely to have mental health problems. So I think everything is more acute and magnified over the winter months for us. So I'm glad that we're talking about this. 30 to 41% is what the RCGP is currently saying of GP consultations involving a mental health component. And I really like something that Mind did, which is a big mental health report 2024. And it was a study of disease burden over 10 years. Really, really interesting to read, and it goes into the real impact of mental health on the population, including things like navigating the benefit system, and differences between gender, suicide, all sorts of different things. We have two speakers, no, one speaker, John Mitchell today from Forward Leeds, and going to be talking to us about understanding substance use, addiction, and mental health in Leeds. So welcome, and I'll give you the floor, and if you'd like to talk to us, thank you very much.
Yeah, thank you very much, Mo. That's really nice to be here. Thanks very much for inviting me. It was meant to be two of us. I was meant to be joined by my colleague Maria Preston, who is a clinical team manager for us and works in the field as well. But unfortunately, she's had to be called away, and it's not unrelated to what we're talking about here, actually, because she's had to step into an emergency situation which involves mental health and substances. So she's very sorry not to be here, but thanks very much. It's lovely to be here. I'm aware that I can't see many faces. I understand a lot of people eat lunch. It's absolutely fine. It's probably really important to find some time to do that in the day. I'm going to, in a minute, share my screen and do a presentation, which should last about half an hour. But I would like to make this conversation, and please do interrupt me. I won't be able to see you when I'm sharing my screen. But if you just want to shout out, or if one of the facilitators wants to say that, raise that there's a question, or if you put your hand up, then hopefully I'll be advised of that. And I'm very happy to stop and talk about things as we go along. Otherwise, my plan is to sort of talk for 25 minutes, half an hour or so, and then hopefully we'll be able to get into a discussion after that about this really important topic. So hopefully that sounds all right. And thank you very much. My Wi-Fi is a little bit dodgy. I'm at home today. If people can't hear me, or if there's any problems, again, please, if someone could shout out and let me know, that'd be great. So I'm going to share my screen now and hopefully be able to see the slides fairly soon. Okay. So can I just check that you can see my slides? It should be the purple front slide. Can someone unmute themselves? Or I've had a couple of thumbs up. That's brilliant.
Yeah.
So fantastic. All right. So I'm Jonathan Mitchell. I'm a consultant clinical psychologist, and as of earlier this year, I'm the clinical lead for Addictions Plus, which is part of Forward Leeds. I'm going to explain that a little bit in a minute, because Forward Leeds is quite a complex organisation. So I'm going to say a bit more about that. And sadly, as I've said already, for those joining late, Maria was planning to be with us, very experienced occupational therapist, clinical team manager, but she's dealing with a clinical emergency today, so can't be here. Okay. There we go. Right. So this is going to be what I'm planning to present today. I'm going to talk a little bit about drug and alcohol harms in Leeds. something of which Mo's already mentioned, and I'm sure people are more than familiar. But I'm just going to share a few facts and figures from our point of view. And then I'm going to give a quick introduction to Forward Leads and Addictions Plus. I hope that is helpful for you, because many of you will be well aware of Forward Leads and how it works, but not everybody perhaps. And then we're going to talk a little bit about the links between mental health and substance misuse. I'm going to talk a bit about who we as a service work with, who Addictions Plus in particular work with. And then I'm going to talk a little bit in general about working with mental health and substance misuse. Discuss just a very few tips and ideas based on research, based on our experience of what works. Talk very briefly about referral pathways. And as I said, I'm very much hoping that the second half of today will be a two-way or many-way discussion when we can sort of share ideas and thoughts, and you can ask any questions you want. But if any people do have any questions midway through, if anything's not clear, then please don't keep quiet. Please do shout out, and I will try and stop and keep an eye on that. Okay. Right. So just a very few headline sort of facts and figures, really. And many of these are taken from the Drug and Alcohol Strategy published by the Council. So in Leeds, the estimate is, and of course it's really hard to be precise about this, that there are over 60 preventable drug-related deaths per year, and that we have a population of something like 5,000 opiate and crack users. There's probably more than that, to be honest. Those are the ones that we're aware of. And many of those, of course, never come to treatment. You may see them in primary care. We may not actually see them in our services. Another estimate from that report was that there are over 10,000 alcohol dependent adults. And of course, there's lots of debate about what we mean by alcohol dependent. And over 35,000 what is termed high risk drinkers. And many of the high risk drinkers won't necessarily see themselves in those terms, of course. That's the definition. Normally is over 50 units per week for men and 35 units per week for women. And many people will carry on drinking that level for a long time and not perceive they have a problem. They may not come to detention services. Other people may worry about their drinking, they may not. But I imagine that many people in your services will have would be classed as high risk drinkers, whether they present with that problem or not. And in Leeds, there are nearly 300 preventable deaths per year from alcohol related conditions. And again, I suspect that's a real underestimate. It's quite hard to really know the true figures for obvious reasons. Okay. So, and these slides were kindly provided to me by Lauren, who and have come from the council as well. It just gives us an indication of the amount of hospital admissions. So this first slide relates to diagnosed drug-related mental and behavioural disorders that have been definitely linked, and this is the main reason why people have come to hospital. So you can see just from the way the graphs are going, that Leeds is a little bit lower than the national average for England, which is somewhat a surprise given we're a large city, I suppose, and we don't do so well on many health indicators. Also, that there has been a slight decline, perhaps over the last few years, but you can see there is that sort of slightly worrying uptick in 23-24, sorry. And I suspect that might be continuing now for various reasons that we might get into later. This next graph shows where drug and related mental behavioural disorders were thought to be a factor, even if they weren't the main cause. And again, we're a bit lower than national average. And again, after a period of slow decline or slight decline, maybe there might be an uptick, and it may be too soon to say. But there's some reasons to be concerned about it, I think. Okay. Hopefully we'll come back in our discussion period thinking about the harms and thinking about your experiences in primary care of what you're seeing. But while I've got you as an audience, I'm just going to talk a little bit about Forward Leads and explain a little bit more about us. So as you may know, we support over 4,000 people now in Leeds. So we just cover the Leeds postcode areas with a couple of little areas of sort of Wakefield postcode and that still come under Leeds. So we're the UK's second biggest service after Birmingham, I think. We employ over 300 people. and 50 of whom are employed by the NHS and LYPFT. And we were CQC rating as outstanding in 2022. That's quite unusual for drug and alcohol serving. It's something we're very proud of. We are recognised as one of the best services in the country. When Dame Carol Black, who some of you may know, did the big government report into drug and alcohol services a few years ago, sort of talks about services, she often uses Leeds as an example of a good service, which is something we're very proud of. And one of the reasons for that, I think, is that we're a partnership. And the main partner is Way Through. They are the people who have the commission from the council. They employ the majority of the people in Forward Leeds. After that, LYPFT provides the next biggest part of the service, and I'll come on to a little bit more in detail about what that is. But we also partner with St Anne's Community Services and Barker. And I've worked in quite a few partnerships involving NHS and third sector partners over the years in different places in the country. And I'm not just saying this, but I actually think that the partnership generally works quite well in Forward Leeds, and I really enjoy working with people from different organisations. And I thought it might be helpful just to show a little bit geographically where we are and where we cover. So we cover the whole area within the black boundary, and our main hubs are the purple dots. So we've got 3 main hubs, one in Armley, one in Kirkgate, which serves sort of the south and the centre of the city, and one in Erford Seacroft, which kind of serves that area over to the east, all the way up to Wetherby, really. And we also have other services. So St Anne's Rehab is a residential detox and rehab near the university, and people who have alcohol issues can go there and be safely detoxed off the alcohol and then engage in rehab to help them stay off when they come out, hopefully. And one of the areas, the services I'm most proud of is in Forward Leeds. It's called Five Ways. And I don't know if any people know where of that. That's in Burley. And that's a fantastic service, which is peer-led. It's a drop-in service. So anyone who's in long-term recovery, who's abstinent, can go there anytime they want, even years afterwards, years after they've been in treatment. They can drop in, have a cup of tea, chat to other people who are in abstinent recovery, and get support and help. And they run loads of wonderful groups, art projects, music projects, that kind of thing. So we've got lots of services. Our 3 main hubs are where people go for their prescriptions, for their initial appointments, for their ongoing appointments as well under Forward Leeds. In addition to that, we do also work in a handful of other services and practices. There may even be some practices here in this call who know that they have some Forward Leeds staff coming in. And we do have some people doing sort of outreach services as well across the whole city. And we also have things like harm reduction vans, which is a brilliant thing, which can go out to the far-flung areas of the Leeds and offer needle exchange and counselling and harm reduction services, and someone quite nice to talk to about stuff. So we try and get out there, but those are the main hubs we work from. Okay, so thinking about what we support people with, this is the substances that people are coming to us with in 2024. So as you can see, not surprisingly, the largest is alcohol. The next largest is heroin. And then following that, cannabis, cocaine, other opiates, crack, and then hallucinogens, amphetamines. And we have a handful of people who come to us for mainly around issues with psychoactive prescription drugs, benzos, solvents, and ecstasy, but that's much, much smaller. Now, it's interesting, this is 2024. Every year, this pattern changes. Alcohol is always the biggest. Heroin's normally the second biggest, but what we're noticing at the moment is that the number of people coming into treatment for heroin is going down relative to other substances. And the number of people coming into treatment for other substances like ketamine, for example, is going up. As the pattern of drug use and the fashions in drug use change across the city, we see different people coming into our services. Right. So I just picked out some real sort of headlines, some current trends that we're noticing at Forward Leeds. So one thing we're noticing is with opiates, who traditionally have been the meat and drink of the biggest part of drug services work, less people seem to be starting opiate use, but we have a cohort who have used for a long time, and they are now getting older. So classically, they're thought of people who maybe in the 90s and noughties started using heroin, are getting older and getting a lot of associated physical health issues. And tragically, we're noticing a lot of people who've been on script for a long time or have been a long time opiate users are passing away or coming into hospital because it seems like a lot of the physical health issues are catching up with them. And that's a real worry for us at the moment. And we're noticing an increase in drug and alcohol related deaths and probably nationally as well. After several years, perhaps of them coming down, we are noticing it, and it's too soon, I think, to understand the patterns behind that. I'd be fascinated if you on the frontline workers have any ideas about that. It's a bit soon, I think, to work out what's going on. Amongst younger populations, we're noticing more and more ketamine use, and that becoming really, really problematic. That's been in the media quite a lot recently, hasn't it? But we're noticing a lot of people in their late teens, early 20s, university age students coming to us with real problems with ketamine and physical health, things that go along with that, which is really a worry for us at the moment. Another concern at the moment across Leeds is adulterants, so things like opiates and spice that are cropping up in a number of places that we wouldn't have seen them before. Things like THC vapes, which are really, really popular amongst young people in particular, but also people trying to come off cocaine and coming off other things. And in ketamine as well, we're noticing these things popping up, and we don't really know what's going on, and this changes all the time, and it feels like we're trying to play catch up sometimes. And there's really interesting societal changes in when people use drugs and how people use drugs and alcohol. And we're noticing more and more people tend to be using it alone in their own homes. Whereas people maybe used to use things socially, and that still very much happens. So there's lots of people that use cocaine, for example, socially across Leeds on a Friday and Saturday night, and they often don't perceive that as a problem, and they see that as part of a good night out. And we as Forward Leeds have got a campaign out at the moment thinking about cocaine use and in various settings, but we're also seeing people using substances more and more in their homes, and for whom it is becoming a problem, and they are unsure about who to turn to and how to get help. And I just stuck that quote in at the end because this came from one of my service users, somebody who's in therapy with me last week, who just commented almost offhand that it's far easier for her to get drugs than it is to get a takeaway to her flat in central Leeds. And that really stuck with me, that all she has to do is to text a dealer, WhatsApp somebody, and she can get ketamine or whatever she wants delivered in a few minutes. And it really struck me that it's and the isolation as well, that she doesn't even have to go out to do that. Someone will drop it off at her door. You can get it posted to you. There's so many ways of getting hold of substances, and it's quite hard to get help. Okay, so because we're talking about mental health as well today, I just wanted to, these stats came from Lauren, so thank you for that. So we've known for a long time that about 3/4 or getting on for 3/4 of people in substance misuse services also said they had a mental health treatment need. And you can see from those stats there that that's across all the groups, opiate users, non-opiates only. So there's like cocaine users, for example. People who use multi-substances, so non-opiates and alcohol, even the highest group. But 72% of the people in the alcohol-only group also said, yes, I've got a mental health treatment need. Okay, where are they getting help for this? Are they getting help for this? So this again came from Lauren. 64% of those people, if they did get help, received it from yourselves in GP surgeries in primary care. 21% engaged with local community mental health services. 2% engaged with NHS talking therapies, what used to be called IAPT. 2% only received NICE recommended interventions provided for treatments of mental health problem drug and alcohol service. So that's the kind of work that I do, I suppose. And it's quite sobering and humbling to think that only 2% of the people actually get help from a service like mine. And that actually a service like yours, which are providing an awful lot of the support that people are getting. And only 1% had an identified space in a health-based place of safety for mental health crisis. So those are sort of the extreme end. That's people who are coming in and maybe receiving having a bed. Okay. All right. Okay. So what are the connections between mental health and substance use? And this is a real area of interest for me. And I think traditionally, when we think about drugs and we think about mental health, there's the narratives that exist in society and amongst many of our patients and many of our colleagues, and maybe in ourselves, is it goes along the classic line of somebody takes drugs and they get mentally ill. And that has tended to be the kind of causal direction that people think about. You know, people make a choice, they do drugs, and then that they have consequences and they end up ill. But as I'm sure you're all very aware, it's an awful lot more complicated than that. That the connection between drugs and substances and mental health difficulties in people's lives is very convoluted, very knotty. And there's some really interesting research on this. This is a useful summary by Nathan and Lewis a few years ago. And they looked at sort of the three, I suppose, ways that you can look at this. So substances do increase risk of mental health issues via both psychosocial and biological processes. So we know, for example, that people smoke cannabis, especially the much stronger versions of cannabis that are around these days. It can really increase their risk of developing psychosis and other mental health difficulties through a number of processes. Um, Also, we know that there's lots of factors about mental health that may contribute to an increased likelihood of using substances. So it can work the other way around too. So I work with people who actually experience unusual experiences or had real difficulties with anxiety and found that one of the few things that seemed to help them with that was using substances. So it's very common as well for people to actually have mental health problems before. And as we know, mental health problems seem to be starting younger and younger, and people are more and more likely to turn to non-prescribed and ways of dealing with that and substances. And I mean, I'm working with somebody at the moment who had a lot of childhood sexual abuse. She found that not very much helped with that. She really struggled to get help. One of the things that really did help her, though, was taking ketamine because it just made it all go away in a sort of a lovely floaty way for her. And it was an enormously, she said she needed to do that to survive a really difficult time in her teenage years. So we know that mental health can also contribute to an increased likelihood of using substances. And of course, number three, there are shared risk factors. And as public people with an interest in public health, you'll be well aware of some of these. I mean, the big one for me is things like trauma, it's poverty, it's deprivation, it's living in a shit part of town where these things, mental health and drugs, are readily problematic and readily available. So there's an awful lot of common factors in people's journeys when they come to mental health and substances as well. Okay. Oops. All right. So I'm just going to say a little bit, and keep an eye on the time, about the NHS bit of Forward Leads, which is called Addictions Plus. So we have five main teams. We have an hospital in reach team. So if someone comes into LGI or Jimmy's and they are dependent on alcohol or dependent on opiates, for example, then we have a hospital in reach team who'll go and see them, who'll work with the ward teams about safely detoxing if necessary, or advising about methadone, helping them through that stay in hospital. And they are a 7 day a week service, 9 to 5 though. We can't do 24/7, but they are there all the time. And we also have a community alcoholic treatment team. And this team you may know from some of your practices because some of them actually work into GP's practices. And they see people for alcohol difficulties in the community, and they do things like home detoxes for people where it's possible, where it's safe. But they provide a lot of support and advice to people who've got problems with alcohol in the community. We have a street therapeutic outreach team who go out to the homeless population of Leeds. So they're based in St Anne's Resource Centre. And they will try and reach out to people for whom engaging with structured services is pretty much impossible. And Maria works for them. And so I'm sad that she can't talk to you a bit more about that today. We also have a pregnancy team for people who are pregnant and who are reliant or on substances, dependent on substances. If you can imagine, there's a lot of issues with them, and we have specialised midwives who try and support them and bring them into hospital and look after them while they're in hospital. And the biggest part of our team, and what I'm going to talk to you more about today, is the COMHAD team. That's the co-occurring mental health, alcohol and drugs team. And we deal with the, as it says on the tin, really, people who come under Forward Leads who have significant mental health issues, because we've seen about 3/4 of people in treatment do have some mental health issues, anxiety, depression, and the like. We tend to see the people with more long-term significant health issues. And the staff in Forward Leads and the staff in, Addictions Plus are a real mixture, a wonderful mixture of social workers, occupational therapists, nurses, psychiatrists, psychologists, and psychotherapists, and also non-qualified professionals as well. And we work together in MDT and share out a lot of these duties. Okay, so as a general guide, we work with the people with the more severe end of mental health difficulties, and significant suicidality as well. So things like, if it was a diagnosis, it would be sort of bipolar, psychosis, so schizophrenia, things like that. And we work with people whose problems will be present even if the substance misuse was addressed. So if it's, say, substance-induced psychosis, they would probably remain under our wider teams, and we work with the longer-term stuff. We offer a lot of services like assessments, mental state exams from psychiatry, formulation work, case consultation, case management. We don't care coordinate, so we're not a CMHT replacement. We work with CMHTs for many clients, but we don't take on care coordination because we can't be a crisis service. We prescribe medication, opiate substitution therapies and others. We do some psychosocial interventions. We do one-to-one psychology and psychotherapy using CBT, EMDR. And we also, we're very proud of this because we're the only one in the north of England who do full DBT, dialectical behaviour therapy, for groups. And we also offer other group programs like the Seeking Safety. And that really focuses on the links between trauma, mental health and substances, and offers psychoeducation to people to understand those links. And we have a lot of links with not just the community mental health teams, but with other LYPFT and other NHS services as well. Okay. Right, so I wanted to just keep this brief, but this is really not just for our service, but this is from the research and really things we can all do, I suppose, for supporting people with addictions and mental health issues. And one thing I think we can all shy away from, including us who work in addiction services, is be afraid to ask, or be shy to ask sometimes, about exactly what substances people do use, and crucially why as well. As a psychologist, it kind of goes against the grain to grill people about this stuff, but I've learned that it's really essential. And even when I'm working with people therapeutically, I will ask them before the session, what have they used today? And how might we might think together about how that might affect how we work together. So really important, and I'm sure you all know about this anyway, but checking where people are at and where they want to be in terms of their substance use and their mental health, and thinking together about how shared plans can get them there. And being aware that drug misuse can present in varied and unusual ways. And I've had to learn a lot about this in the last couple of years, considering cultural and neurodiversity issues. I mean, we're still learning about this all the time. I've got a fantastic colleague who is neurodiverse themselves and has taught me a lot about working with neurodiversity and substances and mental health. And I learned last week about CAT in the Somalian community, which is not something I knew very much about, but it's just about that constant learning, isn't it? And noticing different patterns and different cultural ways that people might present, and crucially as well, what people might not present. I was doing a bit of work looking at who did come to our services and who didn't. I'm very aware that there are elements of the Leeds community who hardly ever come into drug addiction services, like certain parts of people from maybe South Asian backgrounds, people from Afro-Caribbean backgrounds seem to be very poorly represented in our services. And I think a lot of it is about how accessible we are and how where we are and how how easy or difficult it is for people to come to our. And I'd be really interested in your take on those sorts of things, as well as people who work across the city at public health, public health and primary care level. One thing that is a real bugbear for me is when other parts of the system use substance abuse as a blanket exclusion criteria. So quite often people will have mental health issues, they'll try and get support for that, and they'll be told, go away and come back when you've been 6 months abstinent. And often people come and say, how am I meant to get abstinent when the drugs or the alcohol is one of the only few things that helps me just get through the day? So we don't use that, obviously, but also I try and challenge colleagues who do use that as an exclusion criteria and think about that. about how we can work with people where they're at rather than expecting an unreachable standard for some of abstinence for X number of months. And that links to addressing stigma, I think, around substance use and mental health. I think these things are getting a bit better, but there's still a huge amount of stigma out there. Also, I want to point out that we're just one of the places in Leeds where people can access support for mental health and for substances. I mean, last count there was about 30, I think. And some people find our service not very helpful at all, but they find peer services like Narcotics Anonymous, Alcoholics Anonymous, or Andy Man Club. They find those, or Veteran Society, places incredibly helpful. So we're not for everybody, and we need to be really aware of that. And I think as primary care, hopefully you're aware of the many places that people can go and get help. And finally, this is something that I'm learning all the time, that peer support. So it's all well and good to offer professional support. That's really essential, really important at times. But actually, for many, many people, what really helps them get better is having people alongside them on the journey who aren't necessarily professionals, maybe people who've been through it themselves. Okay, so coming to an end now. So the referral pathways into our service is a little bit convoluted, I've got to admit. We do have an open door policy. We do accept as forward leads referrals via telephone or online referral form. So people can just ring up that number there, or people can use online referral forms from under 21s and over 21s, and that will get them into forward leads. When they're in forward leads, then they will have an assessment, kind of a triage, and if mental health is identified as a risk, or if they come under one of the other teams, like they're pregnant, for example, they will then get forwarded on to us. But there are also some direct referral pathways as well. You can see them there for people who are already under secondary care services. That might be a minority of your patients, though, I'm aware. And that's it. So I've rattled through that. I hope I haven't taken too long, because I wanted to leave some time. Yes, we've still got plenty of time, haven't we, for hopefully conversation and discussion. That's my details there. Please do get in touch if you after today if you've got any questions. I'm really keen as clinical lead of our service to reach out and work more with other agencies, and to think in particular about how we can reach out to other parts of Leeds communities who aren't well served by us at the moment. So brilliant. I'd love to have those conversations, and I look forward to working more closely with public health colleagues as well. So I will stop sharing there and open the floor up. And hopefully you haven't all gone away. And it'd be lovely to hear your thoughts and some discussion.
Thanks, Jonathan. That's really insightful. Yes, so I'm just having a look whether we've got any specific questions in the chat first. So feel free to put something in the meeting chat if you don't want to speak. And I think Hasantha wants to talk.
Hi, that's really, really interesting. My name is Hasantha. I'm a GP over at Chapeltown. I was just thinking about what you were saying about the Somalian community, and sort of what you said that people are underrepresented, and is that a clear unmet need? And how do you think you can meet it? Just because I know patients who use spice, there's it seems to be a big issue, and a growing issue, not just in the Somalian community. There's a lot of people seem to be using it. How are you? Well, that's it. How are you trying to kind of unpick that, or get roots in there?
That's a really good question, and thank you for that. I mean, I think, traditionally we as an addiction service have struggled to do that, and I think we still do, I'm being really honest here, because I think we were set up with, sort of the opiate using community and alcohol using communities in mind. I don't think we've been very good always at reaching out to minority communities, and also we know we have an issue with some particular substance. I mean, spice is a really interesting example. So it's an issue in certain parts of the community, like prisons as well. It's a really big issue there. And I think we have tried to do specific projects to reach out. So we were involved in the project reaching out to, I think, called the Gate Project with the sort of traveller community. But I don't think we've been that brilliant at reaching out to particular communities like the Somalian community. And I use it as an example because I'm just so aware of my ignorance really about that community and about what substances they may or may not use. Yeah, I'm not saying we've got it sorted at all, and I'd be really interested in thinking about how we do that better. And I know we've only got a short time today, but I'm trying to sort of perhaps if Pete's got suggestions about how we might do that, which forums might be useful for us as forward leads or me to join and think about how we reach out better to communities in those regards, that would be very helpful.
Thank you. I think Dominic was next, and then we've got Nadia. Thanks.
Thanks, Mohammed. Thanks, Jonathan. That was great. My name's Dominic. I'm a paramedic. I work at York Street Health Practice, so we have a lot of collaboration. So it's really good to hear from you. And I did feel that I wasn't going to learn anything, and I did learn a few things. So that's always useful. So thank you for your time. A couple of things that I thought would be quite interesting to say at this group. So I am a great advocate for mutual aid groups, and this group, and I still use mutual aid groups to stay well. And one of the things that this forum might be an opportunity is we all have buildings that probably aren't used overnight when people need cheap venues to host these meetings. So I would definitely suggest that if that is something you can do in your waiting rooms or at night or those kind of things, that's a really amazing thing that you can do, especially if you're in communities that Jonathan has sort of said maybe there is a cause that we need to improve delivery in these areas. Maybe that's something that you have exactly the right location to do. The point clinically that I was going to open for discussion was gabapentoids. Jonathan, you highlighted a worrying suspicion that drug-related deaths are increasing. And without any hard data, I think if I were to put my finger on the ones that I have experienced over the last 3 years, it is polydrug use, and a big group of drugs be involved is gabapentoids. I think this is probably fueled by a number of different things. I think it's fueled by a thriving economy in illicit sale of synthetic and manufactured medications. I think this is fueled by a reduction globally of opiate availability. But I also think that this is a situation that prescribers in secondary care coming into the community is something that doesn't seem to be a smooth process with a view of starting somebody on something and there will always be a reduction. This is not something that you are going to be on permanently. But I just wondered if, Jonathan, you had anything to comment on gabapentoids and anyone else in the group. Thank you.
Thanks, Dominic. Does anybody else want to come in on that? I know we've got a few hands up. I don't know if you've got other questions or you wanted to respond to Dominic. That's helpful. I think Dominic, thank you for thinking about that. I think we're struggling to see a pattern that seems to be like you said, but I think you're absolutely right about poly drug use and the mixtures of alcohol and substances as well. That does also seem to be a big factor in a lot of the people that we are seeing having real health issues at the moment. And I think it does change all the time. I think you're right about changes in sort of the international availability, like heroin seems to be quite expensive these days, and as well, perhaps because the Taliban have cracked down. But I think you're right about there is that worrying, concerning trend there. So thanks. On my screen, I had Daniel as next. Daniel Byrne is next. I don't know if you want to.
Yeah, thanks, Jonathan. So Dan Byrne, Drug and Alcohol Team at Leeds Public Health. Thank you for that presentation, really informative. You mentioned changing nature of kind of drug use and trends, increases in cocaine use, ketamine use, synthetic cannabinoids, and Dom's obviously also mentioned synthetics, opiates, as well as illicit versions of prescribed medication bought online. There's a big kind of mix over recent years of drugs, and you also mentioned issues around young people in terms of co-occurring drug and alcohol use with mental health issues. Are you seeing an increase there in terms of young people, both in terms of volume, but also complexity of need, and not just around kind of drugs, alcohol, but also things like in the background, rise of social media, etc. within your team?
I think the answer to that is yes. Sure. I mean, I think we are seeing an increase. I was talking to the young people's team recently the other day, and what they're finding is increased complexity. I think there's really interesting interactions with social media, but a lot of young people these days seem to be presenting not just with comorbid drug use and mental health, but also neurodiversity. So lots of people who are maybe on the autistic spectrum or have identified ADHD issues, who seem to sort of an awful lot of these, and the complexity and the interactions of all those things. And it seems to some extent fueled, perhaps, or I don't know the right word, to interact with social media use as well. And yeah, it is a very, very complex picture, and I think more so than perhaps it would have been in the past. It's really hard to unpack sometimes as well, isn't it? I think there's more also trauma for me is always a big underlying factor as well, and it's how people understand, interpret, and describe their trauma, and then deal or try and manage their trauma as well. That it comes out and it's expressed in all these different ways. I feel like I'm waffling, Danny, but I completely agree with you about that.
No, and given that, do you think like over time services will need to evolve, maybe 5, 10, 20 years into the future, and change in the way they address need in this kind of what feels like a rapidly changing world on all of those fronts?
Yeah, I think so. I think we need to have more of a presence in online spaces. I think we need to use technology and help people navigate that sort of thing wisely as well. And we need to be open to the fact that the pattern of drug users and substance users is going to change dramatically. And also, third, we need to be much more aware of neurodiversity, and how young people these days may have slightly different needs to what we've been used to providing. Whereas we used to sort of say, right, this is your package, take it or leave it. But I think we need to be a bit wiser about how we to do that, and that's something we're trying to work on, trying to evolve, and some of our own service users, our own staff with neurodiversity issues, being really helpful for us personally on thinking through our care packages. But it is definitely going to need to evolve in the next 10 years.
Excellent, thank you for that.
I've got Nadia. Sorry, somebody else want to jump in?
Yeah, hello. That's a really great talk. So thank you for that. I'm Nadia Anderson. I'm a GP, but I'm also the clinical director of a network of practices that are based in Bermontoft's Hare Hills and Richmond Hill. So picking up on what Hasantha sort of touched on about those communities who you did mention kind of risk factors in terms of trauma, poverty. It's really certainly in this area where we've got a lot of those risk factors as a baseline, and there's sort of high levels of violence and abuse in general, which children are kind of being exposed to, and that's the kind of childhood trauma. And you did mention already about stigma, and I think certainly there are lots of sort of non-white communities where using substances is highly stigmatized. I think it is even in the sort of white community anyway, but I think there is that added complexity, and I think that might be why, in terms of being actually able to even admit that you need help, is that it's to even sort of mention it to your GP or mention it to family members or all of the other things where people eventually get to the point where they sort of get help or get supported to get help. Definitely it's an extra barrier, and I think certainly that's something I think is of concern, because I would expect then if people are not identified earlier or can accept that they need help, then in the first place it's then they sort of obviously maybe use these substances for longer than they would have done if they don't really see that there is a way of getting help. So first of all, just happy to sort of support and help you getting into Bermondsey, Hare Hills, Richmond Hill. A while ago we had a forward leads worker in my practice, but it was well before COVID that then ended.
Okay. All right.
And you know, a lot of our practices unfortunately are smaller, and we lack estates, but there is a few practices within the PCN who have got possibly spare rooms, and that might well be then a way. Particularly, a lot of our population find it difficult to travel. They find it quite intimidating to travel. They don't have their own transport. There isn't very good sort of transport links going across the city. They're very much, you know, in terms of transport, it's about getting into the city centre and out of the city centre. Going across is difficult. So being based in Seacroft, even though it's only probably a couple of miles, it's quite hard to get there from, say, Richmond Hill or something like that.
Yeah.
So there's really lots I could say, but happy to kind of reach out, and if there is a desire to from yourself or from other people, then absolutely something would be I'd be happy to have a further conversation about.
That's really exciting, Nadia. Thank you very much for sort of saying that. I think that really resonates with me. I was talking to someone the other day about, because if you live in Hare Hills, or at the moment you are supposed to go to Seacroft, and I was up in Seacroft the other day, and there were sort of, you know, flags on every flagpole, and I was talking to a member of staff who's not non-white, and they were saying, I find it hard to come to work at the moment. I don't feel welcome here. Yes, and there's so many barriers, aren't there, to people sort of accessing. So that's, sorry.
Yeah, no, I went to the huge. There's a big Tesco Seacroft, and opposite there is the Britannia Hotel, and I don't luckily see very many flags in Hare Hills, or don't see too many in Moortown, which is where my other site is. But there are lots around there, and it is quite intimidating, you know. And I'm in a car with this with the things locked and everything else. I'm not on a bus or anything like that. One other very quick thing, just I'm conscious that there's not much time, was just about problem drinkers and the amount needed to become a problem drinker, in terms of that 30 units, was it 30 or 35? I've come out on my page where I scribbled it down for women. And I think certainly in as I say, we've got two sites, one's up in Moortown, and I think there's lots which is a bit more sort of leafy, middle class, if you like. But I think certainly there's lots of women who are, as you say, maybe drinking alone. It's not that social sort of thing anymore. Maybe it's sort of a hangover from COVID, that are definitely above those sort of limits, and maybe not recognizing themselves to be in that problem alcohol sort of level, and who would never consider that they should be going along to a sort of a service to get support with that. So just another interesting kind of thing that I thought, yes, and asking people about it, and you know, classically they'll lie and halve it or whatever, but it might make them think, and it might make them sort of consider they're not at that dependent level.
Yeah, no, that's a really good point, isn't it? And I think there is, I share that concern. There's a huge cohort of people out there who we will never see in services. We'll never dream of coming to somewhere like Forward Leads, but who are quietly really suffering. and don't perhaps know what to do and don't know how to get help. And I think some, like Dominic was talking about, sort of peer-led recovery, I think those can be really powerful for instances like that. I think, you know, picking up the phone or going to an AA meeting is really difficult for many people as well. I think we should try and, you know, explore all the different options with people. But I'm so glad that we do need to ask, don't we? And we do need to, that's the very first step, I guess, isn't it? Is asking people about their drinking and how it impacts on them, how they really feel about it, and where they want to be with it. But I think you're absolutely right. Big cohort there that we're not helping very much at the moment. So thank you. Okay.
We have another question that was put in the chat. It's from colleague Obina. I think I'm saying that. Hopefully, I'm saying that correctly. Basically, around patients who say they need a psychiatrist instead of going through the mental health pathways available. What can you say about that?
Oh gosh, so is this people who've got a substance misuse and alcohol and mental health issues as well, but don't want to go to Forward Leads? Is that what you mean? Or I don't know who to look at because I'm not sure who asked the question, but
don't know if Obina is still here and is able to just clarify.
I'll try and find the question.
Oh yes,
chat.
Reply
Yeah,
yes.
Yeah. Okay. So I can't speak for my sort of other psychiatry colleagues in OIPFT. I don't know what your experience is of trying to refer in from primary care to them. All I can really say about that, I mean, we do have a consultant psychiatrist on our team, and we have a staff grade, and we have and people who are under Forward Leads, they can request an appointment with a psychiatrist, even if they're not under the ComHAD team, and we will try and facilitate that where we can. If they want sort of an assessment or they want to discuss their medication with a psychiatrist. So within our team, I can answer that and say yes, people can have an appointment with a psychiatrist without going down the mental health pathway within Forward Leads. I'm afraid I can't speak much outside Forward Leads because you probably know more about that than I do. And if that answers your question. Cool.
Yeah. Thank you for that. Lauren?
Hello, Lauren. I work in public health. I just had a question about kind of Leeds in a city with a lot of universities and obviously like really big student population. And I guess to anyone, not just you, Jonathan, but do you get the sense that young people are still attracted to Leeds as a city, as a sort of high drug using city? Because when I was finishing school and coming to Leeds for university, that was a really big part of what people saw as the draw to Leeds. That's not what I based my decision on, obviously. But I just wondered if that's still the case. Like, is Leeds still seen in that way? And do you think people come here for that reason?
Is there anybody from the university practice here? If there is,
I'm not sure if we've got anyone today from LSMP.
From my point of view, I think the answer to that is yes. I think people, Leeds, it's seen more generally as kind of a party going out, good night out kind of city, and drugs is a massive part of that for a huge percentage of young people. And I think things like ketamine, Leeds is a bit of a centre for ketamine, as with some other cities as well, like Liverpool and other places. But so it's easy to get drugs here, as it's easy to get alcohol here, isn't it, as well? As that, people come for the Otley Run as well, don't they? It doesn't have to be sort of illegal substances. It still has their reputation, is my understanding, and I think people and still really struggle with it. And when they come here, but many young people come here and have a fantastic time as well, and we shouldn't forget that fact. And for many of them, that fantastic time will involve drugs and alcohol. And for the vast majority, that won't be overly problematic, but there is a minority for whom it really is. Nobody else thinks about Leeds as a drugs capital. Danny.
Well, I wouldn't put it that way, but obviously, Leeds is a big city, like all of the big cities across the country, and there's a thriving nighttime economy. There's lots to do in Leeds, lots happening, and you do tend to find that where there are big cities, there are also drug and alcohol issues. Equally, we're in a city where we're embracing things like no and low alcohol drinks, so there's an increase in places selling those, and lots of other things to do. But with all the events and stuff, we're a city that's got one of the biggest music festivals every year as well. Then there is going to be that kind of that magnetism in the same way as we're described as a magnet city when it comes to things like rough sleeping and homelessness, because there's lots of people here. So so it draws people in. But we're doing lots in the city to reduce the harm caused by drugs and alcohol. We've got lots of campaign work going on across both the drugs domain and also alcohol.
Thanks, Danny. That's really helpful.
So we've got a couple of minutes. We've been talking about this sort of thing in our clinical meeting recently. What I wanted to do, I just want to kind of, I don't think there's a specific answer, but how do we stop being how do we continue to be empathetic and show compassion to this group of patients and that we see? And it's hard, isn't it? And I saw some of this play out and observed, and then made my observations in terms of, we're going to have a contract with this patient. Hang on a minute, we haven't even met them yet. Well, they've been in prison, and oh, we're going to have a chaperone. Okay, and yeah. So how do we? And I guess our responsibility is to be keep our staff safe. But then how do we remain compassionate? I don't know if I'm making sense. Sorry, I've had a very overwhelming 2 weeks and a lack of sleep. Yeah, what do you do to remain compassionate in the work that you do? Clearly, you love it. Am I making sense?
Yeah, I think are you asking me, or are you asking people in general? Because I know it's a couple.
Well, I guess you could lead, and maybe our colleagues Daniel and also Dominic have put their hand up, so I'm sure they can share some thoughts as well.
So just like 10 seconds from me. What helps me is remembering something one of my patients told me, that substances are the solution, not the problem, and they mean it's something they did, something they used just to help them survive. And that's really helped me to understand that it has become a problem for them, but actually it was what they needed to do at the time, and there's a reason why people do it. So that helps me. I try and keep that in mind.
Thank you. Dominic?
I can do mine in 10 seconds as well. So there's a challenge to you, Dan. I would say that we are probably in this meeting a group of lovely, compassionate, invested people, and maybe we don't need to worry about that. I think what we need to worry about is our systems. Do our systems show compassion? Do we, if somebody doesn't turn up for an appointment, do we think in the right way? Do we ask the right questions? So do you work in a system that is compassionate? If somebody doesn't respond to a letter and a text, does it just fall off the end of the system, or does somebody actually pick up the phone, or maybe go past the house, or those kind of things? So are our systems compassionate?
Yeah, I like that. I really like that, because what's the point of booking somebody in who's on lots of neuropathics at 9 o'clock in the morning? When you get to know patients and you have continuity, and I think this is one of the barriers, isn't it? If the GPs doesn't, or the health team doesn't know the patient, then they're not going to appreciate that. But yeah, book them in the afternoon and get your team to ring them in the morning and make sure that, or I don't know. But yeah, I like that. Thanks, Dominic. Daniel?
Yeah, I do mine in 9 seconds. So I guess recognizing that there's a person here, isn't there? And that person has not just these issues, probably a whole host of issues. So I won't even list them; they're too long and too complicated. They've either experiencing bad stuff now, have experienced bad stuff in the past, or most probably both. And it's really difficult to deal with that stuff. And drugs and alcohol are painkillers, aren't they? They kill the pain. But also to being aware of a stigma. I think that's such a big thing in our field, and then it kills. Stigma kills. If someone feels that they can't go to a service because they'll be looked down on, they're not going to go to that service. If they feel they're going to be looked down on through drug use, they're gonna hide away. And if they overdose and they're hidden away and no one can find them, their risk of dying increases. So I think there's a lot of work that's been done, and I'm involved in quite a lot of work actually nationally around stigma in this area, but much more to do.
Thank you, Daniel. Thanks so much. Hasantha.
I'll answer in 3 words: trauma-informed care. I mean, trying to keep in mind what trauma-informed care is, and I'm kind of picking up maybe some in between the lines. What Mo's saying is, my goodness, some patients can be very challenging. They can be very angry. They can be manipulative. They're not nice people. We have to be honest. I don't particularly like some of them, but and you have to. But then I keep coming back to this trauma-informed care thing, because it doesn't take much before you're digging before you kind of realise they're on high alert, or they're putting up barriers, or they've got a whole mad. Not the words, maybe not the best word, but they've got a whole way of processing the world that is dysfunctional, and you have to try and keep returning to that thought. Though it's hard, it's very hard.
It's hard. Yeah, it is hard. Natasha.
Hi, can you hear me okay?
Yeah, we can.
Okay,
Hi.
from a neurodiversity standpoint, I think saying that do systems show compassion is a really good point. That was from Dominic. And things like I've heard people saying calls or texts or emails like showing compassion in the sense of acknowledging preferences, but things like that can help with engagement. And considering people's skills and abilities when it comes to technology and being able to get onto these systems in the first place, considering the kind of challenges with neurodiversity, being able to start tasks and being put off by challenging tasks, things like that. Considering things like that can be helpful, but yeah, that's just my thoughts.
Thank you so much. It's really clearly this is a very interesting conversation, isn't it? And I'm sure that it could go on for quite a while, and I think we should probably make a note and come back to this very point. I had a friend who had a mental health problem, and I didn't pick it up for quite a while, and it was using a high functioning individual. And then over COVID, he developed a psychotic episode, and he's never recovered since. And he said, the next time you walk by that homeless person on the floor, just think about how difficult it is when you've got a voice in your head that won't go away. Minute by minute, and it, that really like stuck with me. And most recently, when I was talking to one of my patients, a young patient, who I always ask, so how much are you spending on what you're having, and and then I can work out like how much they're spending. So 40 quid will get you, I don't know, 4 or 5 spliffs, maybe a bit more, I don't know. So I can kind of work it out. And I was having a conversation with this young patient, and he said, doctor, I used to not respect the cannabis, but I respect it now. So I need it. And so actually, I know what I'm doing with it now. And it made me think, thought, he respects the drug and knows how to use it now. So is what he said. So yeah, and I just listened. So yeah, that stuck with me too.
I'm curious
Okay.
to know what he meant by respect. That's interesting. That's an interesting thought.
Well, he knows that it's got harms, and he believes that he's in control of that, and that actually you need to know what you're taking, which I guess is the problem that we start off with. What are you taking? But actually, the dose that is going to be enough for him to do whatever he needs. And for him, it was about giving him an even keel and also being able to sleep. I now sound like I'm promoting the drug, which I'm not. But
there's like, I mean, there is this idea that there's some therapeutic benefit in kind of social spheres. So I guess I can understand how people can come to that thought. So I see what you're saying.
Yeah, absolutely. And look, I went to Canada 3 years ago, where you walk into a pharmacy, is what they call it, and you buy the cannabis. They give you a menu and they say, what do you want, sativa or hybrid, or, and what form do you want it in? And should we give you it rolled up, or should we give you it? And it goes on and on and on and on. So yeah, really interesting world we're in. Very, very interesting world. Thank you so much, folks. The next meeting, Lauren, yes, you wanted to plug this, yeah.
Yeah, very briefly, we will send this out. Rebecca will kindly send this out when we send out the slides for this presentation for today. But in January, our next session, instead of doing an online hour session, we're doing a half-day conference. It's on the 7th of January in the afternoon. We're hosting it at Catch in Hare Hills. And it's about bringing us all together again to kind of think about what we're doing in the system. We're going to do some interactive kind of activities, presentations, and also think about how we take this beyond this group of lovely, compassionate, kind people, and share across the whole of the primary care system, kind of through Target and other methods. So we'd love to have you there. It's free, and we'll send you the details for how to sign up.
Thank you so much. We'll see you then.
Thanks, bye.
Thank you,
Thanks,
everyone.
everybody. Bye.
Thank you. Bye-bye.